Perfect. I'm going to go ahead and get started. I'm Phil. I'm the Navy resident rotating. And today's indications talk is on neurogenic claudication and lateral recess stenosis. We'll also talk about central stenosis, obviously, and then a little bit of foraminal stenosis. So this is kind of the overall roadmap for today's presentation. Lumbar spinal stenosis is a reduction in the volume of the central spinal canal, the lateral recess, and or the neuroforamina, which decreases the space available for either the thecal sac or those exiting nerve roots. This can have a pretty variable presentation, ranging from no symptoms at all to low back pain, radicular lower extremity symptoms, claudicatory symptoms, or any combination of the above. A little bit of background history. So first off, stenosis generally is defined as a narrowing stricture of a passage or canal. The expression lateral stenosis was coined in the 1940s by Dutch surgeon Dr. Verbiest. And then in 1954, he published a detailed description in a case series of 7 males, which all had lumbar spinal stenosis. And then he did a thorough review of their overall clinical presentation and radiographic workup, intraoperative findings, and then the nature of these lesions, which kind of paved the way for a lot of this. Other epidemiologic stuff. So lumbar spinal stenosis is the most common reason that patients are having spine surgery over the age of 65. Back pain in general is the most common reason for indicating imaging studies of the back. And then the most common causes of back pain, generally speaking, are due to degenerative changes, either of the intervertebral discs or the facet joints. There's almost 500,000 laminectomies performed annually for lumbar stenosis. The average age is 64. Slight predilection for Caucasians and males over females. And then almost $1.5 billion of financial productivity is lost annually in the United States. Risk factors for this being symptomatic include advancing age, obesity, tobacco use, and congenital stenosis. So how does this happen? This is kind of a pathoanatomy cascade effect, if you will, where essentially you have your disc degeneration, and then that's going to lead to some collapse of your anterior column, leading to abnormal forces being transferred more so to the posterior column. And then you get ligamentous buckling and then facet hypertrophy and osteophyte formation, all of which can exacerbate the stenosis. Other ways this can happen are degenerative spondylolisthesis or a slip, achondroplasia, congenital stenosis, synovial facet cysts, which can be part of that degenerative process as well. And then other less common would be iatrogenic related to surgery or trauma, systemic inflammatory disease, and a couple of other endocrine disorders. So here we can see lumbar stenosis refers to anything that decreases the area of the central canal or thecal sac, the lateral recess, or the neuroforamen. I think this is the best outline kind of shading of these areas that I could find that makes it simpler to understand. And then generally speaking, we classify the pathology as being either central, lateral, or foraminal. And then you can see the normal anatomic relationships and zones of the spinal canal here. It is important to remember that, by the time a patient is presenting to a spine surgeon, their anatomy is not necessarily going to be completely normal. And then the easiest way to think about this for me is that you have the foraminal zone, which is going to be bounded by the medial and lateral pedicle. And then the central is going to be central or inboard to that medially. And then you can have far out or extraforaminal stenosis, which would be lateral to the bounds of the foraminal zone. So we're going to work this up, of course, with a thorough history, physical exam, radiographic studies, MRI, and then plus or minus diagnostic or therapeutic injections. So central stenosis, in the lumbar spine is classically going to present as bilateral neurogenic claudication. Patients are typically over 50 years old, and they'll complain of an insidious onset of intermittent, crampy, diffuse radiating pains in the bilateral buttock and bilateral posterior thighs. Sometimes also associated with some paresthesias and similar distribution. The way that neurogenic claudication occurs is you have the stenosis and then you get decreased perfusion versus your venous return, which leads to an oxygen demand mismatch. And then we kind of talked about how this will classically present. The neurologic exam is typically going to be normal, but in severe cases, they may have a wide-based cautious gait or blunted reflexes. And then you always want to differentiate neurogenic compared to vascular claudication. So you want to make sure you get a good distal vascular exam and check for pulses. And if there's any concerns, you should work them up further with vascular studies. So this was a pretty cool paper by Penning that went over the functional pathology of lumbar spine stenosis. The Penning rule essentially says that for progressive narrowing of the spinal canal, you're going to have an exaggerated effect in that individual when you compare their spinal canal diameter or stenosis, whether they're in lumbar extension or lumbar flexion. So they looked at the average AP diameter of the dural sac on CT myelograms with patients in flexion and then the same patients in extension, and looked at their baseline central stenosis. So group 1 here on this chart was the control group. Group 4 had the worst stenosis. So obviously, overall, those with the worst stenosis have the most stenosis, whether they're in flexion or extension, but you can see the large difference between the unshaded and shaded bars there with flexion and extension, which can explain the positional dependent nature of these patients' symptoms. There's multiple classifications for central stenosis that look at either measuring the diameter or the area of the central canal. These have been described, but they don't really successfully predict a patient's symptoms, treatment, or outcomes necessarily, which highlights the importance of making sure that the patient's history, physical exam, and imaging findings all kind of align for identifying the underlying pathology. And then axial T2 weighted MRI is going to be mandatory for looking at central stenosis. So kind of lateral recess stenosis now. So the borders of this anatomically, you're going to have the vertebral body anteriorly, the medial wall of the pedicle laterally, and then posterior laterally, you're going to have your superior articular facet. And then more posteriorly, the ligamentum flavum. Etiology for symptomatic lateral recess stenosis from a disc bulge, facet arthropathy, or hypertrophy of that articular facet, osteophyte formation, synovial cysts, or spondylolisthesis. L5 and S1 are going to be the most commonly affected nerve roots about 90% of the time. And unlike kind of central or claudicatory stenosis symptoms, this may be more commonly unilateral or bilateral. And then within this lateral recess stenosis, the patient's symptoms can vary depending on the offending pathology. For example, those with a disc herniation will have more symptoms, perhaps with things like Valsalva maneuver. So how to identify lateral recess stenosis? There's a bunch of measurements that have been described looking at either the height or depth of the lateral recess or the angle of the lateral recess, but similar to central stenosis, this doesn't really correlate well necessarily with patients' symptoms, treatment, or outcomes. So this was an interesting study and essentially looked at the symptom induction in patients with lumbar flexion versus lumbar extension. comparing those with either lateral recess syndrome or stenosis to those with lumbar disc herniation. And you can see here that for flexion, extension, or flexion and extension, patients with a herniated disc were significantly more likely to have symptom induction compared to those with lateral recess syndrome. And then I put some stars to highlight the age difference as well, where you can see that kind of the biggest spike in those with lumbar disc herniations are much more commonly in their 40s compared to those with lateral recess syndrome, or more commonly in about their 60s. This is from that functional study by Penning. So I think it's useful to kind of compare and contrast the clinical findings and sort of radiographic explanations for this, comparing both lateral recess stenosis and central stenosis. So this functional drawing here, on the left, you've got a normal spine, and on the right, or B, you have a stenotic spine. And then you can see the anatomic structure shifting with flexion on the left side of each image and then extension on the right side of each image. And then the larger sort of open arrows demonstrate the functional movement of the disc and the retrodural fat. And then the opening of the canal with flexion and narrowing with extension. And then the small arrows demonstrate the displacement of the anterior lateral angles of the canal, which is the lateral recess. So that's going to move laterally when you go into flexion, and then it's going to move medially or become more stenotic when you go into lumbar extension. And just due to the fact that it is a triangle, the lateral recess is going to stenose starting laterally and then progress medially. But I think this is interesting because it kind of shows a mechanism where if you had stenosis in the lateral recess, you can get what's called medial escape, essentially, into the spinal canal proper, which may explain why those with a lateral recess syndrome are less likely to have a positional dependence to their symptomatology. This is from that same paper. They looked at lateral recess stenosis. You can see the CT myelogram here of the lumbar spine with the same patient in flexion on the left and then extension in the right. And you can appreciate the central narrowing or almost hourglass type stenosis there, which is accentuated when they go into extension. And interestingly, you can see the exiting nerve roots are still outlined with a little bit of contrast enhancement in their sheath when they're in extension and some displacement medially, which is kind of that medial escape mechanism. And because there's still some contrast in there in extension in the sheath, it's unlikely they're having severe stenosis with that movement. Obviously, this does depend on the particular underlying pathology, the severity of the stenosis and its morphology, and the mobility of that exiting nerve root. For example, if it was scarred down, this may not be the case. Overall treatment guidelines for this, non-operative management is going to be first-line treatment and your mainstay. So that's things like physical therapy, anti-inflammatories, activity modifications, maybe some sort of bracing, epidural steroid injections. The results are kind of variable up to 10 years and break down into almost a rule of thirds, where a third get better, a third stay the same, and a third get worse. So it's pretty similar to geriatric hip fractures, honestly. And then surgical indications would be failure of non-operative management, progressive neurologic symptoms, especially weakness, or a mobile spondylolisthesis, which is kind of outside of the scope of today's discussion. And then treatment, big buckets for central and lateral recess stenosis. You've got laminotomy, laminectomy, or minimally invasive approaches. Pros and cons of each are described. So with a laminotomy, you're maintaining the integrity of that posterior tension band, as well as stability. So you have less of a risk of iatrogenic instability if you need to address stenosis at multiple levels or bilaterally at the same level compared to laminectomy. However, the upper lumbar segments, due to the anatomy of those facets, they may require near full facetectomy, and you could potentially do bilateral decompression through the same single-sided laminotomy. And then in a laminectomy, you're going to have your posterior ligamentous complex is removed. And this can cause some iatrogenic instability or iatrogenic spondylolisthesis. These patients have a little bit more postoperative pain. Some studies say a little bit higher risk of a dural tear and epidural scarring. And then in the minimally invasive approach with a tube dilator, this might be changing now as the learning curve in technology advances, but classically a little bit longer of an OR time due to the extra setup, less blood loss and a quicker recovery. But all of these kind of have equivalent functional outcomes for patients, regardless of which approach you're going to use. This is just removal of a hypertrophied superior articular facet. You want to get it out as far laterally towards the pedicle as possible. These are just some tips and tricks for decompression, keys to success. You're going to want to make sure you have good visualization of the offending pathology, and then you're going to want to ensure that you decompress all the way to the medial wall of the pedicle. And then again, the upper lumbar decompressions may require increasing levels of facetectomy given the narrowing of those facets and the angular change as you go more cephalad. And generally speaking, you want to preserve 50% or more of the facet to minimize your risk of instability. This is an intra-op photo, the microscope that shows decompressed lateral recess, medial towards the bottom of the screen and lateral towards the top of the screen there. And you can see that they're all the way out to that medial pedicle wall. Other treatments, there's interspinous spacers, which essentially go in between the interspinous processes and prevent you from going into extension. You can see an example of one of those implants on the right. And then other things you can consider would be a fusion with or without an interbody. This would be for something like a mobile spondy, which again is kind of outside of the scope of today's talk. So this would be incomplete without talking about the SPORT trial. I think this is probably in spine surgery literature, the most well-known landmark randomized controlled trial. They sought to evaluate the effectiveness of surgery compared to non-operative management in the three most common spine pathologies, with lumbar stenosis without spondylolisthesis being one of them. So in this iteration of the study, they compared surgical intervention in the form of decompression versus various non-operative treatments using well-validated patient outcome measures. However, they enrolled 654 patients were enrolled into the randomized cohort, but at 2 years, 67% of the surgery group had underwent surgery, so 33% had not, and then 43% of the non-surgical group actually crossed over and then had surgery. So you can kind of see that graphically represented at the bottom right there. It's like randomizing things and then essentially shuffling the deck of cards. So you're not really comparing what was originally intended. So they didn't find any statistically significant difference in the intention to treat analysis, again, because of this high crossover rate and not adherence to which group they were assigned to. But they concurrently did an observational cohort, which included those in both the randomized and observational cohorts set forth at the beginning of the study. And it was shown that those patients statistically did significantly better than those without surgery. And then those positive results were maintained at 2, 4, and then 8 years as well in the observed cohort, which is an excerpt from that slide here. So you can see kind of that whether you got surgery or not, generally speaking, you trended towards some form of improvement, but those that did have surgery did a lot better. And then some of the effects kind of petered out by the 8-year mark. This study was by the Canadian Spine Outcome Research Network. It was in the Spine Journal in 2019. They looked at patients with lumbar spine stenosis, back pain with neurogenic claudication who underwent decompression. At 2 years, 70% of these patients had improvement in leg pain, 68% improved back pain, and 41% had no pain or minimal back pain. And these results were similar regardless of whether they also underwent a fusion procedure. But importantly, this study also highlighted some patient factors that are predictive of achieving the minimally clinically important differences in their low back pain postoperatively. And they concluded that these sort of good predictors for outcome were absence of narcotic use, the lack of any workman's compensation type claims, and if the patients had increasingly severe back pain before surgery, they were shown to do relatively better after surgery compared to those with a less severe presentation. This was a Norwegian randomized controlled trial published in Open JAMA in 2022. These authors, they randomized patients with confirmed lumbar stenosis to either a unilateral laminectomy with crossover, unilateral laminotomy with crossover, bilateral laminotomy, or a spinous process osteotomy. They were able to achieve 2-year follow-up, and they didn't find any statistically significant difference in any of their primary or secondary outcome measures, except for a longer surgical time in the bilateral laminotomy group. So this study group plans to follow this cohort out until the 10-year mark to study this more closely. So we'll look forward to that in 6 or 8 years. And then a little bit of newer stuff. So there's full endoscopic decompression. This study was done in 2018. It was a meta-analysis published in Spine. They looked at 5 retrospective studies, and they included patients with neurogenic claudication due to central or lateral recess stenosis without instability. They underwent full endoscopic decompression via the interlaminar approach. They had 156 patients. Half were done under general and half were done under epidural anesthesia. And then their ODI scores improved by 42 after the surgery, which was twice the minimally clinically important difference. These authors concluded that you can have successful clinical outcomes with a full endoscopic decompression via this approach, as long as the patients are well indicated. And then they had a range of average operating time from just over an hour to just over 2 hours. Briefly, going to touch on foraminal stenosis. So the anatomic borders of this, again, you're going to have your vertebral body anteriorly. You're going to have your pedicles superiorly and inferiorly, and then your ligamentum and facets posteriorly. The upper lumbar region has more osseous coverage of the foramen compared to the lower. The etiology of this is similar again to degenerative processes, slippage, or alignment issues like scoliosis, which can all cause foraminal collapse. And then there is some static versus dynamic compression here, where there's a decrease in your area of the foramen when you go into lumbar extension. And then the nerve root compression is generally going to show an L5 radicular type pattern, with L4 being second most common at about 15%. And then this slide here is just normal spines without any significant neuroforaminal stenosis. It's labeled quite well. And then on the right here, you can see this neuroforamen highlighted. This is a T1 weighted MRI, and you can appreciate that you can see the perineural fat is hyper intense on this, which generally demonstrates that there's not any significant stenosis in that foramen. Treatment for foraminal stenosis is pretty similar to that for at least non-operatively to central and lateral recess stenosis. Surgical indications for this would include failure 3 to 6 months of non-operative treatment. Again, progressive neurologic deficits, especially weakness, And imaging confirmed moderate to severe stenosis that aligns with the patient's symptoms. Generally speaking, the management of foraminal stenosis you can do in either indirect decompression, ALIF, OLIF, LIF, kind of alphabet soup, plus or minus effusion. Or you can do it direct decompression, which are things like foraminotomies, fascicectomies, or a combined midline and lateral approach. And then again, there's the minimally invasive or tubular approach. So this was a study that looked at some indirect decompression. It was published in Clinical Neurology and Neurosurgery in 2021. The authors were looking to see if ALIF procedures can provide a safe, effective, indirect foraminal decompression. They radiographically reviewed X-rays looking at foraminal height and foraminal area. They only looked at the L5-S1 level. They excluded anyone with spondylolisthesis or severe stenosis. And they found that ALIF provided significant indirect foraminal decompression and improvement in radicular pain. And the increase in foraminal height and area was directly correlated with relief of patients' symptoms. So you can see these are two patients here, two different patients, A and C, preoperatively, obviously, on the left before the hardware and the ALIF. Images on the right, and you can see the sort of wedge outline with that improved disc space. And then these light blue outlines demonstrate the increase in foraminal area. So they got a good indirect decompression there. There's also minimally invasive endoscopic foraminotomies. So this article was from the Journal of Clinical Neuroscience. The authors sought to evaluate radiographic outcomes of endoscopic transforaminal foraminotomies. They looked at L3-4, L4-5, and L5-S1 using cadavers and assessed pre and post-procedural interventions with 3D CT scans. And they had a range of improvement in foraminal heights and foraminal area using an endoscopic approach. And you can see the overlay of the bone that was resected there in the green shaded areas. The reason that they had such a variable improvement in foraminal height and area is because they got significant improvement at that L5-S1, which started out with the most stenosis to begin with. The takeaway from this paper is indirect decompression can definitely be effective if your stenosis is due to disc height loss and you restore that disc height. But direct decompression is sometimes necessary and more effective if you have a long-standing spondylosis due to overgrown facets or osseous pathology that you need to address directly. This is kind of more of that same stuff. Other things to note with indirect decompression, you're going to improve your ligamentous buckling, restore sort of tension in the interpedicular distance with a ligamento-taxis effect, compared to direct decompression where you're going right at the underlying pathology. This is probably more appropriate when you have a fixed structural issue like severe osseous or ligamentous foraminal encroachment. And direct decompression may be more beneficial in the setting, generally speaking, of a central compared to a foraminal stenosis. I'll open it up to any questions.
Awesome, great lecture. Thanks. It's like this is so foundational to like literally everything. And then we just got back from the conformity symposium, but being able to navigate this anatomy is what allows you to do more complex work. Like if you understand foraminal anatomy, understand these concepts of decompression, of foraminal height, where the stenosis is located, et cetera, like really allows you to develop your skill set and do whatever you want. But it's so foundational to any lumbar spine surgery that you do. It's really nice overview and good review of the anatomy. Always good to see. So
What are some?
Yeah, I agree, Greg. Very nicely done, Phil.
What are some tips maybe some of the attendings have in terms of when you're doing, a decompression for lateral recess stenosis? You have a really overgrown facet, and you feel like you're taking so much facet that you're worried about destabilizing it. Do you really just kind of rely on that medial pedicle as your landmark to make sure you haven't gone too laterally and taken too much facet?
Yeah. Yeah, that's, yeah, I mean, I use medial pedicle is a great marker between see the pars as well. Superficial anatomy gets you there. In the revision setting, it's always a little more challenging because some of that's all blown out. But what do you think, Jamie?
Yeah, guys, when we do this work, and you guys will do a fair amount of work, we all do it with me. I think that one of the key things I've learned over years of doing this is that you got to start more medial than you think. So this idea of working, if we're doing a laminotomy, sometimes, especially in the more proximal levels where you have a very narrow interspace, you almost have to take the spinous process away. Those are the times when you almost have to do essentially what we would call essentially a full laminectomy, although typically we're not going to take the entire superior part of the lamin up to the next interspace. I typically don't. I'll create what essentially is a dome. So essentially you're making you're taking part of the spinous process because you need to get more medial to get more lateral. But when you take too much facet, typically you're not medial enough to get lateral enough. You've got to get underneath the superior articular process of the inferior level that you're treating in order to adequately decompress the lateral recess. Typically easier to do at 5-1 and 4-5, sometimes equivocal at 3-4. The anatomy is different at every level in a way. So I think that answers the question as best I can. It's a technical skill set you're going to learn. Hopefully we can teach you under the microscope better. But that's the key. Seeing that feeling the medial pedicle, because sometimes you're not going to see it. And then being able to know that you've got to get further, usually more cephalad to get underneath the superior articular process. That's where the money is. Guess you're robbing a bank. Well, that's where your exiting foramen is, and that's where your traversing nerve root lives as it comes around that medial pedicle wall. So if you don't get all that out of there, it's pretty interesting. You leave enough ligament there, and the nerve root's still not decompressed. So it's hard. It's hard to do this microsurgery well. It really is. Easier to place a screw sometimes.
All right, guys, we'll sign out and sign back into the other meeting. So thanks, everyone.